everyone, and welcome to the Health Equity Jam session, our first session for this academic year. I see a couple more people are joining as I'm speaking. We are so excited and pleased to have a special guest today, Dr. Sonia Angell. And we usually start out with some fun facts, and then we do the formal sort of introduction, or either that or I think the other way around. So maybe what I'll do is do sort of more of the formal stuff, and then we'll do the fun facts to get to know our speaker a little bit more before she starts out. So first of all, Sonia is a friend and colleague, so I'm particularly excited to have her here today. She's an expert in public health, health policy, and systems change who has had more than 15 years of experience in government, from the local to the global level, and she's also remains active in delivery of primary care. Right now, she's the Bloomberg Professor of the Practice of American Health in the Johns Hopkins Bloomberg School of Public Health in the Department of Epidemiology, chairing the Food Systems Steering Committee of the Food Systems for Health Focus in the Bloomberg American Health Initiative. And she's also continuing to practice at Columbia University, Gallegos College of Physicians and Surgeons. Sonia was formerly the director of the California Department of Public Health in 2019 to 2020. And she served through the first wave of the COVID pandemic. She's also a former deputy commissioner at the New York City Department of Health and Mental Hygiene, and has been a senior advisor on global non-communicable diseases at the U.S. Centers for Disease Control in Atlanta. So she's had a lot of experience in public health government, as well as in academia. She's board certified in internal medicine, having done her medical school training at UCSF and her residency at Brigham and Women's Hospital, and a degree in tropical medicine and hygiene from the London School of Hygiene and Tropical Medicine, and an MPH from University of Michigan. So very well qualified. But now we're going to go to the fun stuff. So sometimes I get people to guess, but I'm not really sure if I'm going to be able to see folks in the chat or not. Am I going to see answers in the chat, Lauren?
Yes, you should be able to.
Okay. All right, awesome. So before Sonia became a doctor, though, she had another career. So I want people to take some guesses as to what she might have done in her former career. So let's see if we can get any guesses. Did people hear the music, by the way, too?
Hi, Lisa, it's Allison. We could hear the music, but I'm seeing on my end that it says the chat is disabled.
Oh, bummer.
Same.
Not what we want.
Yeah,
this is
the same.
not what we want for the jam session.
I think it's
Well,
been fixed now. It's
again.
fixed
Here we
now.
go.
Okay, good.
Apologies. This is a new system for us, and we thought we had everything.
All right. So, well,
now
am I getting any guesses yet so far for?
Oh, I like that.
we have a salsa dancer.
Oh, yeah. Because of the music, huh?
I probably wouldn't have gone into medicine if I was a salsa dancer first. I would have just stayed that way.
We sort of threw you off with the music there. Teacher's a little bit closer, right, Sonia? But not quite.
Maybe, yeah.
Sonia, you want to tell us what you did before you became a physician?
Biologist. I like this. So before I became a physician, I was an organizer, and I got interested in medicine because working in communities and focusing really on economic development, it became so clear to me the intersection between the physical health of the community and the economic health of the community. And I felt like there was a calling. So I went back to medical school, but I was an organizer first and foremost, and I still use those skills.
So yeah, definitely a very useful set of skills, especially for those of us who are working to advance health equity and people in public health, being much more community oriented and community engaged. So hopefully we're finally getting people are able to engage with us more, because that's what we really like with the jam session. Well, there's another fun fact. that because Sonia's kind of like a world traveler here, so there's an exciting thing that she once did as part of her travels, and how can you guess? Can anybody guess where she may have spent a night during her travels?
That's a
A very interesting place.
Aruba.
Aruba. Okay. That's a good guess, but not quite.
It's about as high up as you can get.
Yes.
It's chilly. A tree house, that's good.
We're talking. Hey, how did Christina get that? Christina, bing, 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 bing. So tell us what made you decide to do this, to spend the night at Mount Everest, in the base camp at Mount Everest.
Oh, insider knowledge, someone. So listen, so when I after undergrad, I joined the Peace Corps, and I spent 2 years in Nepal as a Peace Corps volunteer, and decided during one of the breaks to go with a friend to camp to trek to Mount Everest base camp. And usually you don't get to spend the night, but as we started to ascend, we got to know one of the expedition teams, and by the time we had gotten to the top, because you had to acclimate at the same level, hung out with them every night, even though we weren't walking with them every day. They were a lot of fun. And ultimately they invited us to stay at base camp and gave us a tent and everything. So we got to not only go and see the beauty of it during the day, but really feel what it's like during night. It was really pretty amazing.
Oh, awesome. Oh my goodness, you're a brave one. Usually when I travel to exotic places, I look for a luxurious hotel. But anyway, that sounds really exciting. And I have quite a few friends who did Peace Corps, so and it definitely seems to be like a place that a lot of people in public health start out. So there's another, this one, she and I probably have in common this characteristic. This is kind of an interesting sort of behavior that a person who is engaged in food systems research might do. So something interesting about our speaker's choice of foods or eating habits. Anybody want to take a guess? Do you think her favorite food is broccoli?
This is my confession. Wow, went from vegan to McDonald's. That's
carnivore. Okay, close. No, not really. But yeah, tell us what your one of your, let's see, vices might be.
Confess to being able to consume an entire pint of ice cream at one setting. And I know that I'm not the only one out there, but I'm willing to say it, and I use it as an incentive to not sit. But that's my confession.
Good for you. What's your favorite flavor?
Maybe butter pecan. Chocolate, that can do it too. Depends on my mood. I try not to do it often, though, I will say.
Yeah. Oh yeah, me too. My favorite is coffee. My latest favorite flavor is coffee.
Ooh.
Yeah. Somebody else loves butter pecan out there, Deidre. So that's awesome. Well, there's another interesting thing about Sonia that I'll share. She didn't share this, but when I heard the music, I thought about her background. And so Sonia her mom is of Puerto Rican descent and dad Australian. So very, very interesting sort of mixed cultural background.
And both from, so US born, first generation.
Yes, yes.
Had a lot of good food growing up and great music.
Yeah, awesome. Well, now we had a little bit of fun. I know it'll be even more fun when we can figure out how everyone can activate their cameras, because people like to turn their cameras on so they can show their faces too, normally. But without further ado, I'd like to turn it over to you, Sonia, to talk with us today. And you were talking about how we are maybe hurting the planet. And I think that is such a timely topic, given everything that we've seen going on with climate change and its impact on health, and especially its impact on the health of people from marginalized communities and low-income countries. So over to you, Sonia.
Okay, well, I'm going to go ahead and share my screen here. And hope that everybody can see this. All right, so does that look okay? Everybody good? Excellent. So as Lisa mentioned, I'm going to talk to you about the heartbreaking effect of hurting our planet. And heartbreaking is really code for cardiovascular disease. I really wanted to anchor this conversation in something very solid. I know we have a lot of physicians that are coming in, and maybe just topical, because very often we speak about climate as some big general issue generally hurting us. And so I think it's helpful for us to really just sort of get down to think about how it affects really much of our work, given that cardiovascular disease is one of the leading causes of death. So as I start, I want everybody to just kind of pause and think about, what is the first word that comes to mind when you think of heart health? Just the first word, and unfortunately, I can't see. Oh yeah, I can see the chat. If you want to throw it in the chat, I'd be really interested to see what words come up. Okay, we've got cholesterol, cardio, the AMA, exercise, blood pressure. Okay, so we've got a mixture of things that are cardioprotective, as well as the conditions that we're trying to protect. Sodium, breathe deeply. I like that one. Two max. All right, now let me see if I can close this. How about, what is the first word that comes to mind when you think of climate change? Not many people have words coming to mind. Flooding, impacted communities, dread, storms, death, frustration, heat, changing weather patterns, greenhouse gases, drought, politics. You know, fascinating, when Americans answer this question in large surveys, polar bears come up pretty often. Fossil fuels, urgency. Okay, so what's interesting though is that the words that we've heard from heart and cardiovascular health and climate change really stand distinct and separate from one another. There's not much overlap in the language or the risk factors. Just to, you know, when we talk about heart health, we often think of that big one-liner: heart disease is the leading cause of death, and chronic diseases, which sort of move along with heart disease, are 7 of the top leading causes of death. COVID made its way, and this is from 2021. The data up through 2020 made its way up into number 4, and we'll see how it continues to persist going forward. But suffice it to say that heart disease is still up there. And when we think of climate change, we think of a lot of the things that you all brought up, of the big floods, of the droughts, of the wildfires and smoke, and all of those things that come along and accumulate with that. We often think of events, and that's what also came up, as you said. And then I think also many of us increasingly appreciate that along with climate change comes this other big event, or risk of a big event, such as a pandemic. So this was an interesting study that was done looking at all. On the left-hand side, you'll see all of the sort of events that you were bringing up and that people think of quickly when they think of climate, which includes warming, precipitation, floods, droughts, storms, and then looked at the impact of perturbation it had on the different conditions that could ultimately lead to diseases that are known to be caused by infections or other factors like animals, fungi, protozoans, plants, and other mechanisms for disease that could be increased through these climate events. And they found that over half of them could be aggravated by climate change, which means that along with these really large one-time events, we consistently live in this world where we are at risk for greater infectious disease. And in fact, when we think about cardiovascular disease, all of these conditions, whether it's an event or a storm or the pandemic, ultimately has a greater impact on those people who have cardiovascular disease. We know that people with COVID-19 and underlying cardiovascular morbidity were more likely to die. And we also know that through large hurricanes and other storms, when we look back at the individuals who suffered most from these conditions, it was cardiovascular disease and other underlying compromised conditions that ultimately led to a greater impact on them. So all of these climate events have a really important role in cardiovascular disease health outcomes and our ability to manage those conditions for those patients. One of the reasons why I wanted to bring this up as part of a conversation is because we know right now the majority of Americans are worried about the harm from environmental problems and really thinking about in their local area, not just generally. And the things that come up as they talk about worrying about them, from either being very worried, moderately worried, or a little bit worried. So all of the green there indicating worry. The most common thing that they're most worried about locally is extreme heat. But pollution, water pollution, electricity outages, droughts, agricultural pests and diseases, water shortages, flooding, tornadoes, wildfires, sea levels, hurricanes, and reduced snowpack, they all rate across populations to some degree. So Americans are worried about the environmental impact of what's happening in our world today, despite the fact that we often have conversations and think that there may be huge pockets of people who aren't worried at all. While it's somewhat true, it's not true entirely. But who's really talking about climate? So this is another survey that was done. This is with our colleagues at the Yale Climate Center, also collaborating with George Mason, doing surveys looking at every year since 2004 at climate and how the public perceives climate. And here I provided the data about how often people hear about global warming in the media. So you'll see about 50% of people hear about it in the media. But what's really interesting is a very small number of people who hear about it from other people. So their colleagues, their friends, their physicians, or other people that they interact with. In fact, it's barely over 20% of people hear about it either once a week or once a month from somebody directly. So even though the media is talking about climate, with one another, we're really not talking about it that much. And that's important. It's particularly important when we think about the role of providers, nurses, medical doctors, and other professionals, because we are trusted. We are very trusted. So when we choose to talk about a topic, we elevate that topic, and the information that we provide is something that people use and consider valuable. So if we are treating and managing patients with cardiovascular disease, or if we're working in a field that is affected by climate related to cardiovascular disease, but we're not talking about it, we're missing a really meaningful opportunity to have a meaningful conversation with patients that really could change the trajectory of their condition. And I'm going to tell you why. So we talk about climate change as if it's sort of this brand new phenomena. And it's true that the conditions now make it almost impossible for us to ignore. But climate change itself is something that was described well in the very late 1800s. And this is a newspaper article from over 100 years ago. It was published in a New Zealand paper in 1912. And it says the furnaces of the world are now burning about 2 billion tons of coal a year. When this is burned, uniting with oxygen, it adds about 7 billion tons of carbon dioxide to the atmosphere yearly. This tends to make the air a more effective blanket for the earth and raise its temperature. So this is not a new conversation per se, and I will tell you, I did a Snopes fact check on this to make sure that it wasn't just circulating on Facebook and had been sort of invented, but in fact, this really did occur. So the idea of climate change has been around for a while. But I think what we often don't talk about so much because we're so event focused is really this, not just highest year ever, but this very remarkable trend over time that started around the 1980s, where really we have not seen the dipping that we had historically in climate and weather. So these are the 10 warmest recorded years that have occurred since 2010. And these are comparisons with the difference of the 20th century average by year. So they look at the whole 20th century, and it's clear that the temperatures are getting hotter. Slowly, they're getting hotter and hotter and hotter. Another really important point is that this is really a life course experience, particularly for those that are born today. This experience of the world getting warmer and warmer and warmer will become an even more important characteristic of their experience of health and their experience with the environment around them. So part of my argument in this conversation here is to get us to really shift from an event-dominated conversation around climate to really think about it more as a life course anchored experience. And if we do that, if we anchor it with life course, we're really going to have very different conversations, and it's going to enter our vernacular in very different ways than if we're simply talking about how hot it is outside, about the heat wave, about the drought, or about the fire. In fact, we're going to be talking about it the same way we talk about issues like equity, where it becomes a lens through which we really need to understand everything the patient experiences. I like this model to kind of understand climate change that came from the U.S. Global Change Research Program. They produce a report every 5 years. The newest one will be coming out later this fall. This came from their 2016 report. And I think it gives a kind of nice way to think about climate and how it relates to health. At the very top here, think of the climate drivers. So this is the direct impact that climate can have. So when we have increased temperatures, it can have a direct outcome of heat-related illnesses due to extreme heat. But the other paths, for example, that it can follow is through the way in which it mediates our social and behavioral context, and through the way it's mediated by environmental and institutional contexts. And through those secondary pathways, it can radically affect the entire experience of entire populations and communities, and then ultimately lead to a very different experience in health outcomes. So for example, when we think about climate drivers that affect housing infrastructure, rising sea levels that make certain areas uninhabitable or dangerous because of the potential for hurricanes and flooding, the displacement of populations through the impact it has on housing results in a very different exposure pathway for that population, a very different level of vulnerability, so that ultimately all of these direct climate drivers can have a very different manifestation on the health of the community. So suffice it to say that climate affects directly, but I think even more important to much of the research we do is these indirect pathways that ultimately affect our patients, and that it's often lost in the conversation when we try to come up with solutions or try to come up with ways to help them deal with their conditions. This is another model that I really like that comes from the WHO. And one of the reasons I like this model is because while it explains much the same conversation, it really centers it around people rather than the climate, which I think is a very important angle for us working in healthcare and thinking about health, is to, rather than approach climate change conversations from a conversation that's really dominated by decarbonization, talking about climate change in a way that's dominated by thinking about how we protect communities and how we use the power of communities to stop climate change. So here, this talks about climate change impacting really, again, sort of the exposure pathways and the vulnerability, but also this bidirectional relationship that climate change has on health systems both helping to mediate or protect communities, but also health systems being impacted and undermined by climate, ultimately leading to climate-sensitive health risks that include all of the diseases that, chronic diseases that we're so familiar with, also as well as infectious diseases through vectors, etc. Mental health is really lifted up here as well, but also the climate-sensitive impact that that climate can have on health systems and health facilities. both as part of this really important discussion when we frame the conversation around climate from a health perspective. I put this up because earlier I mentioned about how that we really need to shift our conversation to think about climate as a life course experience if we're really going to understand how it intersects and moderates a disease experience for our patients. So this is a diagram that was developed when I was part of the Lancet Hypertension Commission in a report that we developed to talk about really what the ideal life course would be when we think about cardiovascular aging from childhood to early adulthood to middle-aged, advanced, and elderly. So the ideal life course for people with respect to heart disease is that they would remain heart healthy. But that over time, because of different pressures on individuals, the average life course looks a little bit more like this. So that into advanced age, it's much more likely that people have uncontrolled blood pressure, resulting organ damage, and cardiovascular disease. We also recognized, and this is an adapted one, that there's certainly another life course that many of our communities that we work and focus on experience, which are those that have this concentration of what was often referred to as the social determinants of health, but also in essentially an amassing of impacts that are create it more difficult for people to have a healthy life course, and so ultimately cardiovascular disease is experienced in much earlier. When we developed this was back in 2016, we weren't thinking about climate. Climate wasn't even on the agenda, and rarely back at that time in the regular conversations that we were having in a public health environment, climate was not integrated into conversations we were having around the social determinants of health. And the social determinants of health were really things like education, poverty, income, racism. However, it's really not possible to think about, I think, cardiovascular disease anymore without really incorporating in an appreciation. So as we really try, the goal being to move us all towards an ideal life course. So really thinking about equity and the impact that it's had on this, on many populations in our communities. Now we really need to think about the additional climate change pressures that it will have on those populations, because if we disregard that, we won't be able to make the advances that we need to in terms of preventing heart disease. So let's talk a little bit more specifically about heart disease. And I want to talk about it, first of all, through the lens of context. So, as we know, context drives the population health outcomes. These are maps from New York City. And across the top, you'll see from left to right maps that demonstrate the concentration of specific variables related to premature mortality and then premature mortality. On the left-hand side, we have the non-white population. The darker areas have a higher concentration of non-white population, poverty in the second map, and then premature mortality. And no surprise, and one thing to make very clear, that the non-white population risk is not that it's non-white, it's because of things like racism and other forms of discrimination that cluster and are experienced differentially by people of color. So across, we'll see tracking that it's the same communities, those communities that are more likely to be people of color, that have higher rates of poverty, that also experience the higher rates of premature mortality. That's not something that you haven't heard before, I'm sure. I'm going to layer on this map, though, which is the heat vulnerability index. And this map shows, once again, the same tracking that we've seen. So this is raised here to really bring into context that this heat vulnerability map is clearly going to affect the same communities. So in New York City, heat-related deaths aren't very many. So there's generally an average of specific 7 heat stress deaths per year, but there's a total of 345 because there's an and also, I'm sorry, there's a number that's not correct in here. the 345 heat exacerbated deaths. So those deaths are deaths that are associated with heat, but not due directly to heat stress, and oftentimes due to underlying cardiovascular mortality. And no surprise in those communities, as I showed you, they are more likely to be communities of color and lower income communities. The Black death rate is 2 times higher than whites. And this, many have argued, is the enduring impact of policies, which are redlining, and the impact it has on climate. So this is an interesting study that was done by Hoffman and colleagues. He looked across the United States, comparing communities that were redlined and those that were not redlined. And actually, redlining had 4 different levels that could be considered. So you all are probably aware, but the homeowners loan the HOLC was responsible after the Great Depression in making designations around communities that would be recognized to receive loans. And their intention, as they described it, was to identify those communities that would be lower risk for investment. And baked into their determination of communities that were lower high risk included looking specifically at race. And in the end, those communities with higher percentage communities of color were more likely to be deemed red hazardous for investments, as they described it. And so red lines were drawn around those communities. The distinctions that were made across other communities included those that were best, those were desirable, and those that were declining, so to speak. And what they saw in looking at the percent of tree canopy, so the amount of trees that were actually in these communities across the United States. So redlining is no longer legal. So comparing these communities, though, and was made illegal in the 60s, comparing those communities that were previously redlined with not redlined and across, they saw a higher percent tree canopy in those neighborhoods that were not redlined, and a higher land surface temperature, up to 10 degrees and more, in those communities that had been redlined. So what we see here is that this disinvestment led to a whole change in the fabric and the community at large, the very clear physical characteristics of the community that have created, still to this day, a lasting risk for heat during heat waves and other high temperature periods. And so when we think about what's happened in New York, this is another study that was done recently by Jaddo and colleagues, looking at, again, at the red line neighborhoods, specifically in New York City, and the prevalence of stroke. So by census tract, they overlaid data related to stroke as well, and then controlled for looking specifically at other social determinants of health and individual risk factors. And what they found ultimately is that the weighting of redlining that was assigned by neighborhoods still demonstrated that even controlling for all of those other risk factors, that redlining had an enduring impact on the rates of stroke, so that those neighborhoods that were historically redlined had higher prevalence of stroke. So now one can imagine, and it's quite clear, that the physical characteristics of these communities are probably quite different, leading to higher rates of stroke. And because of the overlay of increased burden of disease in these communities, because of disinvestment that's happened now over decades, we have a more vulnerable community because of underlying burden of disease now being slammed by higher rates of temperature than other parts of the city, leading to this perfect storm that results in greater risks of death and from both acute and indirect effects of heat. And this redlining isn't just about heat. The same can be seen when you look at the neighborhoods around population. So this is looking at the San Francisco Bay Area. Again, another study that looked across the best, still desirable, declining, and hazardous red lines from the neighborhoods. And you see the neighborhood grade on the left-hand side by color, and then the levels of nitrogen dioxide pollution in 2010. decades later again, and the percent of people of color again. So communities of color being exposed to this disproportionate level of pollution. And we know that air pollution is one of the leading risk factors actually for death. So globally, over 7 million people per year die from air pollution. And the effect, one of the ways in which it does so is through its effect on cardiovascular health. I also want to note that there's also evidence to show that in utero, fetuses as well as infants that are exposed to air pollution are also, there's been studies to show that they're more likely to develop cardiovascular disease. So this is another way through which our climate and what we're doing to our climate is increasing our risk for cardiovascular disease. So what about physical activity? So we can say, well, great, well, we can offset some of this, right? Let's just recommend that people spend more time doing physical activity. All right, so this is a study or an indicator that's been developed by the Lancet Countdown, and it was reported in 2022 for the first time, which I was thrilled about. It really looks at the intersection between climate and physical activity, which is a really unique way to think about an indicator for something that is really part of the bread and butter recommendations of cardiovascular health, be physically active. So what's the impact of climate on physical activity? Well, this indicator begins to give us a little bit of a sense of that. So what it's shown is that over time, so if you all have spent time on this Lancet Countdown or have not spent time on this Lancet Countdown website, it's fascinating. You can manipulate the data and look at a number of different indicators. Here I looked at the United States only. So we have over time from 1990 to 2020, and it's comparing from a 1991 2000 baseline to now. The difference in the amount of time or the risk of moderate heat stress during light outdoor physical activity. So in the United States in 2020 compared with 1990, people are at have 1.28 hours more per person per day of at least a moderate heat stress risk during light outdoor physical activity. That means that when you encourage people to ride their bike, to avoid driving, when you encourage them to be physically active as a sport, these are things that people will be deterred from going forward. So as well, again, this is not one of the big events that we all talk about. This is the slow, insidious impact that climate can have on some of the very key recommendations we have for cardiovascular health. So then you might be saying, great, so we'll just eat well. I mean, we'll eat super well and we'll protect our hearts that way. No, that's not going to happen either. Not if climate has its way or at the climate change trend does. So let's talk a little bit about the impact that climate has on food and food access and nutrition. So climate can certainly change the insects, weeds, and fungal populations and lead to increased pesticide use, which is a problem. Higher rates of carbon dioxide actually can increase food yields, but at the same time, it can decrease the nutrients that are in the foods. So our vegetables are less likely and will have been shown to have lower levels of nitrogen, potassium, phosphorus, calcium, sulfur, magnesium, iron, zinc, and copper. So micronutrients. So the very nutrition value of our food would go down. And so while I told you that CO2 can make crops grow better when it's combined with increasing temperature, that can offset that growth benefit. So for every 1 degree increase in Celsius temperature, for example, there's a 5 to 6% decrease in wheat barley production. And you can go across all of our basic staples and see differences due to rising temperature. And then ultimately, we get disruptions because of temperature issues that lead to changes in disclement weather can disrupt. And when we combine that also with some of the civil issues that are going on globally right now, one can easily imagine that food prices will go up, nutrient profiles will go down, access to food will go down, and as a result, that final recommendation we had of improving nutrition as a way of protecting your heart also becomes compromised by climate. This is a study that looked at only at the population of under 200% and was looking specifically at food insecurity, and noted that the probability of chronic health conditions, even in this population, goes up even greater when people are food insecure. So while poverty definitely can result in higher rates of chronic conditions, food insecurity is its own independent exacerbator. So as we talk about issues around access to food that can result from climate, again, those very low income communities becoming food insecure will lead to exacerbations and increases in the probability of cardiovascular disease as one of the number of chronic conditions that increases as well. How about our food system? What is going on with our food system? One that we really need to support a population of 10 billion people by 2050. How can we change our food system if we're really thinking about ways to enhance and improve health? Well, one of the ways we can think about it is how we change consumer behavior in a way that really drives the way that we use our environment and our environment's resources in a more healthful way, one that is less destructive. And that is a place in which health really has a specific role. So this slide here shows the at the very top, you'll see the different types of colors of along the food production process by color, the pathways that one would go through in order to produce food from the development all the way to the delivery of the individuals. And so the different processes include land use, farming, animal feed, processing, transport, retail, and ultimately packaging to get it to a consumer. So this graph shows greenhouse gas emissions. You'll see across the horizontal and across the vertical by different types of foods that we eat. And by and large, you'll see that beef is one of the largest producers, not only of greenhouse gases, but if you also look closely at this, it's really being driven not by packaging, retail or transport or processing or even animal feed. The things about producing beef is about farming and land use changes. So when we change the amount of beef that we are consuming, the impact that it can have on land use and farming is pretty profound. So then what do we do? So we understand that we have these systems that aren't working, right? And we understand that the specific risk factors for cardiovascular disease are being exacerbated, and those preventive measures that we recommend are also being undermined. So we have a perfect storm really here for increasing cardiovascular disease in the setting of climate change. So I would say that one of the strengths that we have as we think about this and try to grapple with solutions is that the strengths that we have in numbers. I talked a lot about specific communities as we were really trying to talk or emphasize the reality of an inequitable impact of climate change on certain areas. But by and large, climate change is happening everywhere, and no one is free from the experience that climate will have on them. So in a way, really, we have an opportunity to build partnerships across many different groups that historically we may not have been engaged with before. And just a reminder again that this is a life course experience, and particularly for those that are born now, they're coming into an environment where they're going to be even more activated to do something about this, because if we don't act very soon, the results could be catastrophic. And again, the opportunity and the importance of making sure that we act now is the only way that we're also going to be able to address the really the important impact that it's going to have on our communities that are already experiencing extreme inequities. So there's two ways that are particularly talked about, include adaptation and resilience. The third is mitigation, which I'll get to in a minute. But when we talk about the way in which we can be engaged in climate in health, it's typically through one of these two mechanisms. Adaptation is the process of adjustment to an actual or expected climate event and its effects. So really, it's trying to moderate the harm or exploit beneficial opportunities. That is different, though, from resilience. And resilience is really more of a focus on the system itself. It's focusing on the capacity of a system to be able to cope with a hazardous event or disturbance, and also responding or reorganizing in ways that maintain its essential function, identity, and structure. And these are two ways that we hear about a whole lot of investment on the health side. One of the really important reports on climate change and health and how to protect us came from a collaboration with the Trust for America's Health and JHU. Our Megan Lockshaw here at Hopkins in the School of Public Health was one of the lead authors on this as well. And this was really looking at how we could build strength through preparedness for climate, focusing on those event conversations we've had in local and state governments, but with a heavy emphasis on states and state preparedness. Many of the ultimate recommendations include investments that need to occur, and many have not to date. So part of the conversation that we really need to be having, I think, as health professionals is, how are we investing? How are our states investing in the kind of mechanisms and tools that we need to have in place to protect our communities? And these things just aren't happening, and certainly not at the rate that we need them to. Another way through which a lot of work is going on, and this is a presentation in and of itself, is around environmental justice itself. So Biden's administration, the Justice 40 initiative, has committed to deliver at least 40% of overall benefits from federal investments in climate and clean energy to disadvantaged communities. This is another tool and a federal mechanism through which a lot of these dollars could be considered. One thing I really note, though, is that many of these dollars aren't necessarily going through health departments or other health organizations to get to the communities. They're really moving through a community that has historically focused on environment as its primary focus. So while it is about environmental justice and it absolutely affects health, there is lots of space for health to become a more active participant in not only the organizing, but also really thinking about how to frame some of the opportunities to maximize impact, working and supporting the directions that the communities are taking. So even though we have adaptation, and it makes a whole lot of sense to think about how to protect our communities when an event occurs, what can we do about mitigation? So mitigation is really mitigating those things that cause climate change, decreasing CO2 and greenhouse gases. This slide is from the International Panel on Climate Change, the most recent report. And it shows across the bottom by years from 2020, you'll see where the graph really sort of starts right now, through to the year 2100, which is impossible to believe, but it seems so far away. And the impact of the implemented policies that were currently occurring. So, and this is the direction, and you look on the left, it's the temperature. So for us globally, the implemented policies that are occurring won't keep us below the 1.5 climate increase. We're already at 1.1. It will end us up at a range of around 2.2 to 3.5. So to limit warming to 2 or to 1.5, we need to be behaving radically different, which means we need to have everybody working on this issue. So my question and my proposal to all of us would be, how do we really think about health, not only playing an important role in mitigation or in adaptation and in resilience, but what should we be doing, or can we be playing a role in mitigation, in reducing our carbon footprints? And I'll offer just one specific example, though I think there's many more, and there's a great opportunity for conversation around this as well, which is in New York City. Mayor Adams announced that he's going to take pretty major steps, which is to reduce greenhouse gas emissions of all foods in New York City by 33%. So any foods that are purchased by the city ultimately by 2030 need to have an aggregate 33% less greenhouse gas emissions. And this is going to be done by city agencies using the procurement policies. And so in order to do this, there was a baseline that was created to help understand what kinds of foods were being purchased and what is their relative contribution to greenhouse gas emissions. So this is New York City, New York City's total food purchase by government. And I thought this was really interesting and wanted to share it with you because the donut on the left is food purchases in kilograms. And you'll see that about 3% of all of the food by weight is beef and lamb. And if you look at the right-hand donut where it shows its relative contribution to greenhouse gases, they're responsible for 42% greenhouse gases. So what New York City has been doing is really thinking about how do we target and think strategically about reducing our greenhouse gas emissions in the most effective way. And for them, they found that the most effective way to do this would be to reduce beef, lamb, and dairy products in purchasing. And so that is one way that a city is looking specifically at reducing its greenhouse gas emissions, its carbon footprint, through just thinking strategically about purchasing. And the reason this is such a health lens is that we also know that a recommended diet would be one that has less beef and lamb than, or beef at least, than is currently consumed in the American diet. And so this is one of those co-benefits where the actions of the city to protect the climate are all the same actions that would be desired to improve cardiovascular health in particular, but health at large. And New York City's public health hospitals have also cut their emissions. So they're serving more vegetables, and as a result, their emissions have been cut by 36%. So in summary, I just to conclude and then hopefully have a conversation about this perhaps through chat. This is really I really wanted to raise the role of climate change and its impact on cardiovascular health as really an all of health all the time issue, not an event-based issue. And given that cardiovascular disease is one of the leading causes of death, and as I've shared for you, there's a lens through which we can look at cardiovascular disease through every one of these ways in which climate is affecting us. This is something that we should reconsider throughout all of our work. The same way that we think about using an equity lens to understand how our programs or activities are having either positive or negative effects on that goal of improving health for all. Likewise, a climate lens is something that is really essential if we really want to continue to support both our equity desires, but really our just human health and cardiovascular health goals at large. Much of this work, though, and the questions that we ask will be answered through transdisciplinary work. This is a space where a lot of the information doesn't necessarily sit in the training of a physician or a public health worker who was not necessarily trained in environmental health. So this is a huge opportunity, again, to build out and work with partners that we've never worked with before. Through health, we can certainly use the tools that we have to enhance adaptation and resilience, but we should think more critically also about mitigation, because the more that we're a part of the conversation around mitigation, the more that we're going to be engaged in the much larger conversations about decarbonization of our energy supplies, and these larger conversations, which are about moving resources and reshaping the distribution of access to resources in communities. So I would argue that our expertise is really needed at the table, but we also need to develop our own expertise to be there to have very clear conversations about climate and its impact on the health of our communities, cardiovascular and otherwise. So with that,
oh, wow. Thank you, Sonia. That was so thought-provoking and just enlightening. You know, I mean, I know many of us have been hearing about climate change here and there, and that it's related to health and all those things, but I thought you just did such a fabulous job of showing us like how it actually is connected. What are all these different pathways, and how the equity agenda just sort of definitely is aligned with anything we do, and climate change is actually sort of critical and fundamental to our equity efforts. So thank you so much for that. And I'm sure everybody else feels the same way. I see Deidre has turned her camera on, so I don't know if you have a question for Sonia. The one thing that I can think of right now is like, what are we doing? I know we probably are doing things in the School of Public Health. Are you aware of what we're doing educationally in public health and in medicine to sort of prepare us to be better informed contributors to this agenda?
Yeah, I mean, I think there's a number of efforts underway to really sort of cross-fertilize. I know there's conversations that the National Academies of Medicine has been really focusing on. I'll give the example of the care delivery system itself is responsible for 8.5% of all greenhouse gases. So the care delivery system has a role in this conversation. The care delivery providers, likewise, to be trained to be able to understand and be able to talk about this is a whole other set of training needs. And there are trainings that are rolling out and they're available online, but it's certainly not enough. And I think we're kind of on the back step on this in many ways. This isn't something that many of us had training in when we started. And so this is one of those places where dissemination of ideas and information is going to be something that's going to be a cross-generational conversation, as well as us becoming tooled ourselves to be able to teach others.
All right. I can only imagine. I'm sure my great nieces and nephews are going to be like teaching us a lot about all of this because they've had to really experience so much more of it than we have. I'm just thinking about this summer where so many kids couldn't even really enjoy summer camp because it was just so hot that they had to stay inside like most of the time, you know.
Yeah.
So Deidre, do you have a question?
Yeah, so thank you, Sonia. This is really, really fantastic and so informative. You were touching on this towards the end of what you were sharing, but I was wondering about, like, I was listening to the news a few days ago about was someone speaking about how we have made some progress, right? Because I think we often think about climate change as something that we just, with sort of a fatalistic kind of attitude towards it. It's going to have effects. There's really not anything we can do, I think, is the way it's been framed for so long. And I was wondering where you see the opportunity for us, working in the health equity space to sort of make that argument that we actually can, we can do something about it, and what kind of examples might we be able to share to make people feel hopeful and hopefully be activated as a consequence of feeling more hopeful about what can be done?
Yeah, so I think we're at a really special moment right now where there are resources that are being made available at the federal level through the EPA and others to really think about how we might advance, particularly through environmental justice action in communities. So I think one of the key things through this is that this is the really amazing part about the environmental justice movement is that it's about communities defining what their needs and defining the direction that they go in. And I think the opportunities for academic institutions is to both learn from and think about what kinds of additional inputs might be possible for those communities in ways in which we might collaborate with them. Some of the really interesting examples are using data that's available to understand where social vulnerability is across the United States and to really help enhance dollars that are getting into the hands of communities so they can be leaders in their own right around these activities. I think the other piece is that despite all of these dollars that are available, still the CDC, for example, the Office of Climate and Health has a budget of $10 million. It's been $10 million for over 10 years. $10 million is nothing if we were really going to work with the CDC as our leadership to work with other states and local jurisdictions to be able to create the resources that local communities need to be able to be active. So I think another really important space for us to be in is through advocacy as we think about how to help think about framing the resource needs for those conversations at large.
I think that's such an important point. And it's like, I know, well, public health is definitely always sort of the under-resourced issue. And then you sort of add this climate change component, which already has a lot of is very politically charged, and you combine that with the public health piece, and I can see why it's been an uphill battle. But I think working, like you said, cross sector and cross disciplinary work can actually, I think, bolster the argument from several different angles for the urgency of addressing it. So I'm looking forward to becoming more engaged in the conversations for sure. Are there other questions from people? I see a lot of smiling faces on the pictures. I think I'm guessing a lot of people are just letting a lot of this sink in, Sonia, because it's like, wow,
All right. I mean, I would just sort of put out there as you reflect on this, we in health, we are kind of in the business of trying to support changes in behavior. And the way we behave is how we got where we are. The way we consume things, the way we desire things, the way we are advertised to desire things, what we purchase, that's how we ended up where we are in terms of our consumption patterns, and which ultimately leads to different changes in land use, which leads to deforestation, which leads to increased carbon release, decreased carbon capture. And so it's like this circular experience. Because in health, we're in the business of helping people be their healthiest through behavior change. When we start to use a lens, it's a climate lens, to also inform behaviors, we can really impact the way in which we are either producing or not producing greenhouse gas. And so the simplest way we've talked about it is simply the way one thinks about their individual diet, right? So eating a diet that's good for the planet is also good for our heart. But we also know that an individual's food choices aren't necessarily always their own choice. They're choices that are given to them or promoted. So as we think about these environmental changes that are a part of good public health behavior or good public health practice, when we think about all of those things that we try to change around the social determinants of health to keep communities healthy, if we think about the climate in that context too, if we think about, for example, through the lens of food, as New York City did, there are many different ways that I'm sure, being as creative as we are, and with the community leadership, there are many different ways I'm sure that we could make changes in our environment so that our carbon footprint would be different. And that leadership could and should come from the communities itself, but it isn't something that any of us are going to be engaged in if we're not sensitive to it and actually looking for it, which I think is really it's that moment in time right now.
Yeah, absolutely. Thank you so much for bringing that perspective to us as well, and connecting it really to cardiovascular disease, which many of us work on, cardiometabolic conditions. So, are there any other questions for Dr. Angell or comments?
I have a question. So has anybody's, I started this by asking what the first word was that came to mind when I asked about climate. Have their words changed? Do you remember what your word was?
Yeah.
Yeah, well, my word was politics, and I think you, sort of it. I think the list expanded. I guess the list of of words, but yeah.
And I was much more thinking about things like the events, like you said, storms and heat and air pollution and things like that. But I'm definitely thinking much more now about health and about communities and how they can be engaged.
Yeah.
I see someone, let's see, what did someone say in the chat here? Place-based factors, Gracie is saying. Yeah, that's true. Yeah. I knew this whole thing. I guess my brother-in-law a few years ago became vegan, and he's like definitely someone who ate a lot of like steak and all of that. And one of his reasons for doing that was supposedly he was being more conscious of his contribution to carbon in the environment. And so I thought about that, but I think I have not been as informed about sort of like the kind of the agricultural practices and sort of like, I hadn't made the connection to actually on a system level, kind of the purchasing practices and things like that, that could actually bring about much broader, change.
I mean, food production is responsible for almost 1/3 of all greenhouse gas
Yeah.
emissions. It's responsible for 70% of all deforestation, and so fresh water use as well. So it alone really can have a knock-on effect if we really think about how we participate in the food system and food production at large. And then the other thing to think about when we talk about food systems is there's a lot of other byproducts of the food system that negatively affect communities, which can be, particularly when it's perturbed by changes in climate. So we think about our agricultural workers and the impact that climate has on the quality of those jobs and their health as just one example. There are many different ways along that whole process when we purchase a piece of whatever our food choice is, depending upon where it comes from, that climate, that carbon footprint and the impact it has on communities is substantial.
No, I know it's huge. And when I think about even like the developing world and, how much of an impact this could have on reversing some of these processes could have on health in the developing world, it's incredible.
So I think what the conclusion that I've come to as I've spent more time in this area, because I'm not a climate expert either, but I am a public health expert, and I know it's very clear that if we don't figure out how to work in climate through a public health lens, we're really going to miss the boat here, since it's affecting so much of what we have. And what I'm realizing is that we have a lot of research that we need to do. We don't know what those policies are specifically. We don't have that full menu of policies that we should be pushing for public health institutions to be really advocating for, that we know will have both the health and a climate impact. We have some examples of a few, but we don't know what the full menu is. We don't have good surveillance to really understand what the interaction is of climate on health. Those measures aren't readily available. I gave a really nice example of one that came from the Lancet related to heat stress and the number of hours per day, but those aren't typical, and they're not, many communities aren't necessarily using indicators like that allow us to find the words and the numbers to describe what's happening. So there's lots of opportunity for research and activity in this area. And so if any of you are interested in really becoming more engaged in this, I think we're creating a learning community, and I'm more than happy to explore areas where there are big questions that need to be answered, because we need to answer them quickly, and we need to answer them. Health needs to answer them. Our communities need to answer them. We can't wait for the energy community to make a decision about how to go green. We need to be a conversation about how to green our energy supplies as well. So we need to learn more about it. We need to understand more about it, and we need to drive with health in that conversation as well.
I definitely appreciate that. We sort of brushed the surface of this in my third term course last year, but you're definitely giving me more food for thought, no pun intended, for this year. Well, I think it's about 4:15, and I think I'm gonna let everyone go. I know it's a beautiful afternoon outside, and we've been gathering in the virtual space, trying different things. And I apologize for the glitches that happened today that caused people to not be able to engage in the chat or turn their cameras on for a while, or maybe even to get into the platform. So hopefully we will fix some of these problems, but it's been good to gather together and to have Sonia just sort of spark our series for the year with such a fabulous presentation. And we're definitely going to be thinking more about this as we pursue our work and reaching out to you for additional collaborations. So thank you so much, and thanks everyone, and we will see you next month at our speakers at our jam session, second week of November, I believe, right? All right.
Thanks. It's a pleasure to join today. Thank you.
Thank you. Okay. Bye.